Welcome everyone to the MSRA 2022 High Yield Revision webinar for doctors applying for specialty training. So for those that haven't met me before, just a brief introduction. My name is Muhibur Rahman. I'm a portfolio GP and a consultant in medical education. I'm one of the authors of the National Prescribing Safety Assessment that doctors normally do when they're going into F1. I've been an examiner with the GMC for their PLAB Part 2 and an invigilator for the GMC between 2017 and 2020. And I continue to examine for Liverpool Medical School for OSCEs for third year and final year. And I've been teaching about SJT, the MSRA, specialty training, GP careers, because I'm a GP, for coming up to past 16 years now. And at eMedica, our team have trained now over 51,000 delegates. So, we've got a lot of experience in helping people get into specialty training and get through their membership exams. For those of you that maybe haven't heard of the term of a portfolio GP or a portfolio doctor, that's basically just means I'm a GP with different roles. So I'm a partner in my own practice. There's two of us, and that's in central Birmingham near the city centre, and we've been seeing patients throughout the pandemic. But I'm also one of the resident GPs at a secure unit for women with significant mental health illness. So it's a secure unit. They're mostly detained under section. They have a psych team that looks after their mental health, but myself and the other GP, we look after all of the preventative medicine, sort of screening, physical health, chronic illness, and things like that. So that's taken there. And then I have worked over the years with various organizations. So as well as running courses for eMedica, we've run joint courses with RCGP, Bedfords and Hertfordshire, with Health Education England, East of England, Kent, Surrey and Sussex, and various schemes. And this course was actually taken just before the pandemic started. One of the last big face-to-face courses we did in Bedford. It was a joint course with RCGP and Health Education England. So that's really what a portfolio GP is, someone with different roles. I've got different clinical roles. I've got different non-clinical roles. So in terms of the format today, I'm going to start with an overview of the MSRA, and then really we're going to get straight into high yield revision. So we're going to do some exam style questions. We'll do 7 clinical questions first, then we'll move on and do some SJT questions of each of the 2 types. Then we're going to talk about revision planning, how to not just pass, but to really get the best score possible so that you can get your first choice job, how to succeed. So this is what we're going to go through. I'm going to start with an introduction to the MSRA. Then we'll look at how the different specialties are going to use your score. Then we're going to do some practice questions to look at both important topics and develop some technique for the clinical paper. Then we'll do the same for the 2 types of SJT question in the professional dilemma paper. Then we're going to look at why do people fail to either pass the exam or pass the exam but fail to get an interview or fail to get a job, and how to avoid those. And that will lead nicely on to how to prepare effectively for both papers so that you don't just pass, you smash it. Finally, there'll be the live Q&A, although we will be taking questions throughout. The bulk of the questions will be dealt with in this session here. And we should finish around 9:20, okay? So in terms of the overview of the MSRA, MSRA stands for Multi Specialty Recruitment Assessment because it's used as part of the recruitment process for lots of different specialties to recruit primarily into ST1 or CT1 level, okay? So what happens is if you want to apply for one of the specialties that uses the MSRA, you apply for training via Oriel. You don't apply for the MSRA via Oriel. You apply for training via Oriel. If you haven't already submitted your application, I suspect some of you have, remember the deadline for that is the 1st of December. No late applications are accepted for any reason, okay? And then they will look at your application and see, do you meet the eligibility criteria to be longlisted? And then those that meet the criteria and are longlisted, they will be sent an email to invite them to book a slot for the MSRA on the Pearson VUE website. So you don't book the MSRA on Oriel, you book it on Pearson VUE. That's expected around the 21st of December. The actual dates for the exam for round 1 are the 6th to the 15th of January, 2022. And you'll have a choice. So when you get your invitation, you'll log in and you'll see the different centers and the different dates available and the different time slots, okay? So, pretty much any date within this window, apart from the Sundays, most Pearson VUE test centers are closed on Sundays, you'll be able to pick, and there's Pearson VUE test centers all across the world, okay? Now, you cannot sit this as a standalone exam. So sometimes people ask me, why can't I find where to book the MSRA? Remember, you can't just book it. You apply for specialty training. If you don't meet the eligibility criteria to apply for specialty training, then you will never get an invitation to book the MSRA. You can't just book it as a separate exam. It's not like MRCP, you know, a qualification or anything. There's no qualification attached to this. This is part of the recruitment process. So you apply for one of the specialties that uses it. Now, each specialty has their own eligibility criteria, okay? So you can look through the person's specifications and then fill in your application in Oriel, all right? Once you're longlisted, you get that invitation. So what's going to happen on the day of the actual exam? So it lasts 2 hours and 55 minutes in total, including a 5-minute break. That's for standard timing. So the whole thing's done on computer, and there's 2 parts. The first paper is always the professional dilemma or SJT paper. That lasts 95 minutes. Then you have 5-minute interval, and then go straight into the clinical problem solving paper, which is 75 minutes. Now, the timing for these 2 papers is separated. What I mean by that is, let's say someone finished the SJT paper, the professional dilemma paper, in 90 minutes. They can't have 5 minutes extra for this paper. You see, you're doing 2 separate papers back to back with a 5-minute break. It's not all one exam, if you like, because, you know, if it was all one exam, someone could say, oh, I'm going to spend a bit less here and have a bit more time here. It doesn't work like that. Let's say you finish this with 10 minutes spare. When you click start here, you'll still only have 75 minutes. All right. They're 2 separate papers done back to back. And there's multiple equated test forms. What does that mean? When you click start, you'll be randomly allocated one of multiple versions of the exam. The person sitting next to you on the same day might have completely different questions, but all the questions are graded. So you'll have the same proportion of easy, medium, and hard questions. And you have the same proportion of questions from different curriculum areas so that we can compare someone's score that sat it in Nigeria to someone who sat it in Australia, to someone who sat it in England, to someone who sat it on the first day compared to someone who sat it on the last day. Okay. Now, lots of different specialties use the MSRA. These are all the different specialties that use it. Okay. So all of these use it for ST1 or CT1, except for nuclear medicine. Nuclear medicine is for ST3 specialty training. So if I launch the poll, you can pick more than one option. Select which of these specialties you have already applied or are applying to, and that's why you're sitting the MSRA. Some of you might be applying for more than one specialty. Most people only apply for 1, but some people apply for 2, okay, maybe even 3. So, you know, you can apply for as many as you want, but you fill in a completely different application on Oriel for each one. You only sit the MSRA once if you're applying for more than one specialty that uses it. The same score will automatically be put into Oriel for each specialty that you apply to, but you have to fill in a full application separately for each specialty on Oriel. As expected, the most popular specialty of all specialties is GP, and that's what most of you are, you know, sitting. About 70% of you have applied to GP on the session today. And then other ones that are really popular, I'd say the second most popular one is radiology. Also one of the most competitive ones, okay? Then we've got ophthalmology, anaesthetics, lots of people for either psychiatry or child and adolescent psychiatry, quite a lot of doctors for obstetrics or community sexual and reproductive health. Emergency medicine, again, only started using it last year, quite a few people for that. And not many people for neurosurgery or nuclear medicine, okay? Both of those don't have many jobs anyway. There's not many numbers there, all right? So now each specialty uses the score in slightly different ways. So you sit the exam once. A score that might get you a job in one specialty might not even get you an interview in another specialty, because the level of competition is different in different specialties, okay? So let me show you how the different specialties are using the MSRA score for 2022 entry. So for GP and for psychiatry and child and adolescent psychiatry, MSRA is 100% of your rank. There are no selection centers, no OSCEs for GP this year, no interviews, no portfolio station. Similarly for psychiatry and child and adolescent psychiatry, 100% of your rank and your chance of getting a job and the job you want is based on how well do you score in the 2 papers in MSRA. The 2 papers are equally weighted. There's no interviews or portfolios for psychiatry or child and adolescent psychiatry this year. For obstetrics and for sexual and reproductive health, it's 25% of your total, the other 75% being made up of, you know, things like your portfolio and how you do at the interview and so on. However, the reason I've put this up here is that for obstetrics, if you can score really well, if you're one of the real top scorers out of all obstetrics candidates, then it's possible to get a direct offer and skip the interview stage. Now, they haven't set what the exact score that will be, or the top how many. Will it be the top 5%, the top 10%, the top 50 candidates? They haven't said that, okay? But it's possible to get a direct offer and skip the interview if you do really well in the MSRA. All of the other specialties, your final rank is determined part by the MSRA, part by either shortlisting questions on the application in some specialties, or in most specialties, portfolio and interview, making up the rest. But you see, on top of that, because all the other specialties are really competitive, most of them will use the MSRA to actually filter out candidates, and only the top scorers will get interviews. Okay, so for example, emergency medicine, 40% of your rank is MSRA, the other 60% is about what happens at interview and portfolio. However, there's limited number of interview slots and lots of people apply. So if you don't get a really good score, you may not get the chance to show your portfolio or have an interview. Neurosurgery and nuclear medicine, again, it's 40% MSRA, 60% is everything else. Radiology, competition increased significantly last year. I expect it to be even more competitive this year. Okay, so it's a third of your total rank. The other 2/3 is interview and portfolio. However, they will only interview about 600 candidates. So if you're not in the top 600 scorers of those that apply to radiology, you could have a brilliant portfolio, lots of things you've done to show commitment to the specialty. You might be really good at interviews, but you won't even get an interview. You won't have any chance of getting a job if you don't score really well. The cutoff to get a score good enough to get into interview has been going up and up the last 3 years for radiology. Ophthalmology, it's 20%. So the other 80% is about interview and portfolio, but again, limited number of interview slots. If you don't score well in MSRA, you won't get an interview. And Anaesthetics, similarly, it's only 15%, but there's limited interview slots. And a lot more people apply than there are interview slots. Something else that's important, pediatrics used the MSRA last year. They're not using the MSRA this year. So if you're applying for pediatrics, you're not going to have to sit the MSRA unless you're also applying to one of these specialties. Okay. So let's move on then to start doing some questions, right? We'll get straight into the meat of it. So let's start with an overview of the clinical paper. The clinical paper is 75 minutes, and in that time, you're going to answer 97 questions. Gives you about 45 seconds per question. It's tight. However, only 86 questions carry any marks. Every paper will have 11 questions that are there for piloting purposes. They don't look any different. They won't have a little asterisk or a star. They won't be in a different color. You know, you need to take all 97 questions seriously and answer all of them. But there will be 11 that are worthless. They carry 0 marks. Now, there's 2 main formats. Extended matching questions, which come in sets, set of 2, 3, 4, or 5 even, okay? 3 is common. And single best answers, which are just one question on one topic. Extended matching questions can have lots of options, up to like 10, 11 options, okay? Usually have about 8, but it can go higher. Single best answer questions usually have 5, but they can have 6, 7. You know, they can have more than 5. So this will make up almost all of the questions in the clinical paper. You may get 1 or 2 questions of other formats. So sometimes historically there have been some algorithm questions where they might show you a picture of part of a guideline, and you might have to drag labels into the right place to show you know the guideline. Historically, there were the odd picture question. I might show you some blood results or something like that, and you know, interpret it. There haven't been as many in recent years, okay? And you might get 1 multiple best answer. So that's a question where there's more than 1 right answer, and you get more than 1 mark for it, okay? You may not get any of these. It might just be these, all right? So let's look at what's being covered and the level of knowledge being tested. So they set the exam at the level of knowledge expected of a doctor who is in foundation year 2, i.e. you've already been practicing clinically for, you know, more than a year now. So they expect you to be able to take histories, to know what red flags are, to make diagnoses, to manage, you know, the emergencies that a junior doctor should be able to manage, to think about risk factors, to think about prescribing. Do you see? It's harder than finals, but it's not at the depth of membership, because what makes the clinical paper challenging is not the level of individual questions. There will be some hard ones, some medium and some easy. It's more the breadth. So this is the curriculum. And I've put these boxes to represent the proportion of questions in the exam, okay? So there will be about as many questions to do with cardiovascular medicine as dermatology, ENT, and eyes combined. Similarly, there'd be as many pediatrics questions as there are cardiovascular. There'd be as many musculoskeletal as infectious disease, hematology, immunology, allergies, and genetics combined. There'd be as much psychiatry and neurology as reproductive. Do you see? So you want to spend a fair amount of time preparing for all of these subjects. So that's what makes it challenging. It's really broad. Now, whether you're applying for radiology, GP, psychiatry, you're not going to have a different exam tailored to your specialty. The MSRA, the curriculum is the same for all specialties. Okay. So let's start with a set of 3 extended matching questions. So what's going to happen is the way it's laid out, there's only ever 1 question per screen. As I mentioned, you've got about 45 seconds per question. Okay. So what's going to happen is I'm going to show you 3 questions in a row. The screen will automatically move forward after each one. I won't launch a poll, just write down your answer at home. After you've done all 3, I will go back over them and launch polls one at a time. It's because if I explain the answer to the first one, it might give you the answer to the second or the third one. You're not going to have that in the exam. So I want you to actually experience it first. Okay, so first question is going to kick off. During the question, you won't see or hear me. Okay, I'll turn off my video so that you're not distracted. Okay, so here we go. First question is coming now. Okay, so we're going to go through the answers now. I will remind you of the question. I'll launch the poll. Please use the poll to select your answer. Okay, so while you're doing that, I'll just remind you of the question. So the first one is a 45-year-old patient that got stage 1 hypertension that needs drug treatment. Okay, not on any medication, otherwise fit and well, and ethnicity is Asian Bangladeshi. So the most suitable medication to prescribe for this patient. Okay, that's time. So the 2 really popular answers, most people picked A, ACE inhibitor, and then after that, the other popular answer was C, calcium channel blocker. Very few people picked the others. A handful picked some of these lower down, but this was a 2 big one. This one was the most popular, and then second most popular, calcium channel blocker. Okay, and so the correct answer is A, ACE inhibitor. So well done, most of you got that right. Why is that? Well, we'll come on to that afterwards. Okay, because we're going to go through the guideline. Okay, let me go through the. Actually, I'll do it first. So why is he given an ACE inhibitor? Well, because the patient's not diabetic, they're not Afro-Caribbean, and in that case, what we look at is age, and his age is under 55, and so ACE inhibitor would be first line. So that's why it's A. Okay, that's the NICE hypertension guideline. I will go over it when we've done all 3 questions, but just to highlight, that's where it's coming from. So let's do the second one. So I'll relaunch the poll. So this time, this patient's 54, and they're Caucasian, and they've got stage 2 hypertension. They're not on any other medication, and they don't have other medical history of note. Okay, so what will be the first line drug for this patient, the most suitable medication to prescribe that? Okay, so now here, similar proportion have picked A and C as last time. A few people picked A or B. The correct answer is A again. Now, a little bit of technique here. This is what I call the EMQ trap. All right, we just covered the guideline. This patient's not diabetic. He's not Afro-Caribbean. So we look at age. His age is under 55. So he'd have an ACE inhibitor. Now, let me know in the chat, is there anyone that actually thought it was an ACE inhibitor, but then thought, why would they put 2 A's in a row? And even though in your heart you felt A was right, and you actually wanted to click A, you then changed your mind and changed it to either B or C. Is there anyone that did that? Let me know in the chat. Yeah, so a couple of people have said that they've done that. See, this happens in the exam, that sometimes if you don't have confidence in your own knowledge base, then it's really easy to think, oh, you know what, they've put this here because they're trying to get me. I'm going to show them, I'm going to change my answer. Some questions might seem like, some of you might have thought this is really easy, especially having just done the first one. You know what, some questions in the exam are really easy, but you know why they're easy? They're easy because you've worked hard and you've learned your stuff. You might have recently treated a patient with something like this, or you might have read the guideline, or do you see? So if a question seems easy, part of technique is having confidence in yourself. This seems easy because I've worked hard and I know my stuff. Select it, move on. Don't overthink things. No one's trying to get you. We want you to get in. We want you to finish your training, get your CCT, get a consultant level or GP level job. That's what we want for you. All right. So, sometimes as doctors, we sabotage ourselves when we don't have that confidence in the hard work you've already done. Okay. So, if you're naturally drawn to an option, there's probably a good reason, is that you read it somewhere or you remember it. Stick with your gut. Okay. Right. Third one in the set is usually the hardest one. So this patient's 60 and they're Nigerian and they've got diabetes already, and they're now diagnosed with stage 2 hypertension. So he's on a statin and he's on metformin for his diabetes. So what's the most suitable? Now, what does that word mean? It means suitable for this patient in this scenario. That's what suitable means. Now, this is the harder one of the set, okay? And that's evidenced by the breakdown. So about 40% of you picked calcium channel blocker. That was the most popular answer. Then just over a third picked ACE inhibitor. And then about a fifth picked ARB. And then a few people picked some of these down here. Okay, so the correct answer here is ARB. So only a fifth of you got this one right. This is a hard question. Okay, the first two would have been graded easy. So why is that? Well, it's picking up this here. So, sometimes someone will not get a question right because they don't have the knowledge. They haven't learned that guideline. And that's okay. There's lots to do. If you're not working in a specialty where you're dealing with this, unless you read it, we wouldn't expect you just to know it. Okay. And so other things you might have missed, the ethnicity is really important here. So the fact that this patient is Nigerian, okay, is really important. So the fact that they're diabetic, and even if you missed it here, the fact that they're on metformin is another clue, right? So again, remember, what does most suitable mean? It means suitable for this patient in this scenario. So what we've got is someone who is of African heritage, who's got diabetes. And so if we look at the guideline, this is the NICE guideline for hypertension 2019. It's the current guideline that we use. At step 1, when you're deciding to start someone on drugs, so they're not on any drugs for hypertension yet, to decide whether they start on this side, the A side, or this side, the C side, you've got to ask 3 questions in a specific order. Question number 1, are they diabetic? If they're diabetic, you're going to start on this side. You don't need to know their age if they're diabetic. Okay, it's not relevant. Next question is ethnicity. Would they be considered a Black patient of African or Caribbean ethnicity, heritage? Okay. If they're not diabetic, but they are of Afro-Caribbean heritage, then regardless of age, it's going to be a calcium channel blocker. If they're not diabetic and they're not of Afro-Caribbean heritage, then we need to know age. And if that age is under 55, like the first 2 patients, then it's going to be an A-class drug. And if they're 55 or more, it's going to be a C-class drug. So why did this patient get an ARB? That's knowing the rest of the guideline. And that is that A means ACE inhibitor or ARB. For most patients, it'd be ACE inhibitor first line And if they can't tolerate an ACE inhibitor, you might put them on an ARB. Type in the chat, what's a common reason patients don't tolerate an ACE inhibitor and we have to change them to an ARB? Common side effect. Because you'll often get questions about drug side effects, you see. Yeah, absolutely right. A dry cough is very, very common. Yeah. Okay. But you see, if you read the full guideline, one of the things you'll see is for Afro-Caribbean patients, the latest evidence shows that when they need an A-class drug, ARBs are much more effective than ACE inhibitors. So whenever someone who's Afro-Caribbean needs an A-class drug, you should start them on an ARB first line. So do you see? So this patient, because they're diabetic, they go down this side. And then because they're African heritage, then A means ARB for them. You see, A equals ARB for the patients of Afro-Caribbean heritage. So that's why they're going on an ARB first line. So whichever one you start, you optimize it. At the second step, you add either of the other classes. So for example, this patient, if you optimize their ARB and they're still not controlled here, you could either add a calcium channel blocker or a thiazide-like diuretic. So not bendroflumethiazide, that's specifically mentioned in the guideline not to use, but a thiazide-like diuretic, like indapamide. Okay. Similarly, if you started someone on a calcium channel blocker, not well controlled, optimize that. Here you could add in either an A-class drug or a thiazide-like diuretic. Optimize both. Step 3, they're on 3. An A-class drug plus a calcium channel blocker plus a thiazide-like diuretic. It's only at step 4, if you've optimized these and still not responding, this is when we start thinking about further diuretics like spironolactone or alpha blockers or beta blockers, because some of you picked those options, but these patients were all over here. We're, at the first point of starting one drug. Okay, so that's the nice 2019 guideline. So let's now do a set of 2 EMQs on investigations. Okay, again, same format. Here we go. Okay, that's time. Let's go through the questions. Okay, again, we'll launch the poll. So first one, here's the poll. So this is a 70-year-old patient, and they're in a nursing home. They've got dysuria, nocturia, and frequency, but they don't feel thirsty, and there's no blood, no hematuria. Okay, so now this is an example of a 2-step question. In a 2-step question, the first step is always very straightforward. You can see the second step is what gets you the mark, the most appropriate diagnostic test. Remember, appropriate means for this patient in this scenario, not a generic question, and diagnostics, or to make a diagnosis. The first part, though, is working out the likely diagnosis. What is it we're trying to exclude? What is it that we're trying to include? What is it that we're trying to diagnose? So that's the first part, right? Type that into the chat, and you'll see what I mean, that the first step is always very straightforward in a 2-step question, because we're not trying to catch anyone out. So what's the thing that we're trying to diagnose? UTI, you can all see that, right? Typical features. Why have we added that, doesn't feel thirsty? Because otherwise, actually, with these symptoms, you might think about diabetes, right? And the test that you'd want to do to diagnose diabetes is going to be completely different, okay? Similarly, if they had hematuria, especially if it was frank hematuria, you might be thinking about cancers and things like that, okay? So we're thinking about a UTI. So what's the most appropriate diagnostic test for this patient? Correct answer is B, urine culture and sensitivity, okay? And, well done. About 2/3 of you got that right. The most popular incorrect answer, so most of the rest of you picked urine dipstick. Okay, why is that not appropriate for this patient? Because of the age. Okay, so let's go through investigations for suspected UTI. If you had a woman under 65 and they had no risk factors for complicated UTI, actually a urine dipstick can be used to aid diagnosis. So for example, if leukocytes are there, nitrites are there, red blood cells are there, and they've got typical symptoms, is more than 90% chance that they'll actually have UTI confirmed if you sent a culture. So we don't bother sending a culture. That's enough. You could just treat them. Okay. But if they're 65 plus, or if they've got any of the risk factors that either make the dipstick less accurate or risk factors for complications, then you need to do a culture because a dipstick's not reliable. So 65 plus, someone who's got a catheter or recently had a catheter, someone who's pregnant, someone who's got persistent UTIs, recurrent UTIs, UTIs not resolving after antibiotic treatment, all of those, you need to send a culture. A dipstick's no good in this situation. So you see, for this patient, because she was 70, dipstick's no good for diagnosis. Okay, so do you see, again, that's technique. Some of you might have known that, but just in a rush, you missed this one factor. Okay, because if this lady was 30 and everything else was the same, then urine dipstick would be fine to make a diagnosis because you've got typical symptoms. Okay, right. The second one, if I launch the poll, so this time you've got a child who's had multiple UTIs over a long period of time, over a year. What's important is that the last episode ended 4 months ago and they're well in themselves now. So what's the most appropriate test? Again, what's that key word mean? It means appropriate for this patient in this situation. It's specific. Okay, great. So popular answers are urine culture and sensitivity, KUB X-ray, and then DMSA scan. Okay, so these are the three that were popular, right? Actually, NH, just scroll down and saw H. Abdominal ultrasound was actually one of the most popular answers. It was the second most popular answer. Okay, so the correct answer is DMSA scan, and less than half of you got that one right. Okay, as I mentioned, popular answers being other popular answers, abdominal ultrasound and KUB film were the other two really popular ones. Anyone know what DMSA stands for? Why does everyone call it DMSA rather than the full name? Because the full name's a real mouthful, isn't it? Okay, it stands for dimercaptosuccinic acid. Okay, so if someone's got a UTI, I'm talking about children, okay, children 3 and over, if they've got an atypical UTI, then during the acute infection, we'd do an ultrasound. If they've got a recurrent UTI, that's this patient, right? Multiple UTIs over a period of a year, recurrent UTI, then you do an ultrasound within 6 weeks of the acute infection, but then you do a DMSA scan because you want to look at long-term changes 4 to 6 months after acute infection. So again, if we go back to the question, you say, look, 4 months ago, they had the acute episode. It's too late now. If you wanted to do an ultrasound scan, you would have done it 6 weeks after the acute episode. 4 to 6 months after, we want to do a DMSA scan. So again, you could be in a rush and just miss this one thing. Because if this was, I don't know, a month ago, it's too early to do the DMSA scan. A couple of weeks' time, you probably would want to do an ultrasound scan. Okay. Right. And then we're going to move on to a couple of single best answers. So single best answers, you see, they tend to have one question, and then there's commonly 5, but often you might have some questions with more. Okay, so here we go. So key thing here is that this is someone with metastatic cancer, terminally ill, severe nausea and vomiting, and now we're thinking about a syringe driver. And to do well in the clinical, it's about 90% knowledge. You put the hours in, you learn the material, you cover the material, okay? And you could cover the material by practicing questions and reading the answers, by reading, focus reading from textbooks, by reading guidelines, things like that, okay? But a good 10%, and 10%, by the way, could be the difference between getting an interview and not. It's hundreds of places in the national ranking, okay? Is technique. And part of technique is reading carefully and watching out for certain keywords. So one of the key things is, this is what we call a negatively framed question. Which one of these would be least helpful in alleviating these symptoms, i.e. severe nausea and vomiting? So the majority of questions in the clinical paper will be positively framed, i.e. it'll ask, what would you give? What is appropriate? What would you prescribe? What is the diagnosis? But you'll have some which will say, which are the least likely diagnosis? Which is least helpful? Which would not be suitable? Which would not be appropriate? And if you miss that negatively framed keyword, you might have the knowledge, but still get it wrong because you're in a rush. So the correct answer is B. Hyoscine hydrobromide won't help with nausea and vomiting. What do we use that for? For excess respiratory secretions or bowel colic in a palliative care setting. Do you see? So that would be the least helpful. Whereas a lot of you picked dexamethasone. Dexamethasone could be helpful in a situation like this. What could be a cause of severe nausea and vomiting in someone with metastatic cancer? What type of mets? Type in the chat. Brain mets, absolutely. Dexamethasone can be really helpful in that situation, okay? Similarly, cyclizine, haloperidol, levothyroxine, all of these are useful for severe nausea and vomiting and often used in a syringe driver in a palliative care setting, okay? Whereas this is useful in palliative care, but not for these symptoms. It's useful for these symptoms. So do you see, if you either didn't know that, you might get, not get the mark, but if you knew it, but missed that it said least helpful rather than just so helpful, you might quickly say, oh, this would be helpful, and click it. Which is what, let me know in the chat, did anyone do that? That you thought, oh, this would be helpful, and that's why you clicked dexamethasone, because actually that was the most popular answer, dexamethasone. Okay. Right, let's do one more, and then we'll move on to SJT, infectious diseases. Okay, thanks very much. So every single answer has been picked. Popular answers are A, B, and then D. These are the three popular ones. So again, you can see that they've been given doxycycline because what are we thinking about? Lyme disease, right? So what would be the classic finding? What's the name of the rash that we see in Lyme disease, the classical rash? It's called erythema migrans. Looks a bit like a target. There's a central red bit. Sometimes you'll actually see where the tick went in. Okay, sometimes the tick will still be there. Okay, and then there's a pale part, and then there's another ring on the outside, right? Okay, so erythema migrans. Okay, so what's the likely cause of the symptoms? Correct answer is D. Because they've been given doxycycline, and because of the time period that it's happened, we'll be thinking about the Jarisch-Herxheimer reaction. Okay, about just over half of you got that right, so that's actually really good. Normally it's less than that, so well done. So the Jarisch-Herxheimer reaction, it can happen with any antibiotic treatment, but it's very common with some. It's so common with doxycycline in Lyme disease. It's one of the things that we specifically warn patients about. It happens in about 15% of patients. So that'd be considered a really common side effect. Okay, usually it will occur within the first 24 hours of starting treatment. And the reason it happens is actually because the antibiotics are working. So because they're working, they're killing the bacteria. And then there's a release of toxins, okay, from killing the organism. And that causes a worsening of like the fever, the chills, the muscle pains, headache. It can also cause, if we go back to the scenario, a little bit of a tachycardia. This is mild. It can cause a little bit of a drop in blood pressure, and it can cause facial flushing, okay? And one of the things why we warn patients about this is that often they will think it's an allergic reaction and want to stop, but actually it's a sign it's working and they need to carry on, okay? What's the other common illness antibiotic that you would see the Jarisch-Herxheimer reaction in? Type into the chat. Another one that is really famous. So syphilis, okay? Leptospirosis is a bit less so, but syphilis is the other really common one, okay? So in terms of clinical, how to prepare, we know that in terms of long-term retention, active learning is better than passive learning. So an example of active learning is what we've done now. You're actually thinking and clicking. When you're doing some online questions, you're actually thinking and clicking. An example of passive learning is reading. If you just read a textbook, if someone asks you to regurgitate some facts, you might be able to. When you have to apply it to a case or a question, it takes a bit more processing power. Now, that doesn't mean there isn't a place for passive learning. Ideally, you want to do a mix of both. But for example, if you are reading, if you then think, okay, how can I make these into bullet points and make it concise? That process of thinking about it and putting it in your own words helps to put it into long-term memory, okay? What you want to do is allow enough time to cover the curriculum systematically. Now, I know most people that are on today are already using our online revision service because we invited you, a lot of people through there. So that's great. You've already started because the exam now isn't that long, 6th to the 15th of January. If you're sitting at the beginning of that period, can you see we've got a month and a bit, all right? If you're sitting it towards the end, you've still got less than 2 months. So hopefully, I know some of you have already been revising for a few months. Anyone that hasn't started revising, if you're planning to sit the exam in January, we're revising today, but from tomorrow, please start doing questions. Please start doing some reading, okay? And you want to practice realistic questions, and you want to work on your exam technique. So part of that is by doing realistic questions, try to do some to time, try to sort of look at when you get something wrong, why did I get it wrong? Was it because I haven't read that subject, I'm not familiar with it, I haven't looked at it? Or was it because I misread that keyword, I misunderstood that it was negatively framed, or things like that. So I'm just going to show you now, whichever online question bank you're using, I'm show you with ours because I have access to ours. So on ours, there's a study guide. Please download that at the beginning and read through that. Then we've got clinical questions mapped to the curriculum. So you can see these are mapped to the same headings. So the way I recommend that you do it is, if you're going to start, say, with cardio 1, when you click that, there's 30 questions there, okay? When you finish those, don't do cardio 2, because if you do all the cardio at the beginning, when you get towards the exam, the last time you read any cardiovascular was like a couple of months ago, you start forgetting. Do all of cardio 1, then do all of respiratory 1, then do all of gastro 1, then ENT 1, then peds 1, then neuro 1, then derm, then heme, then obs and gynae, then psych, then MSK. Do you see all the way down? And we've got some mixed surgical. So these are like all the different surgical specialties are in the exam. But there's some things that cross more than one. For example, if you've got a child with suspected torsion, that sort of fits urology and it fits pediatrics. Okay, if you've got reproductive ruptured ectopic, for example, fits reproductive, but also can sort of fit across other specialties, right? Okay, and fits into sort of emergency management. And when you're doing questions, when you're reading the question, so by the way, in the exam, it's just like this. Every question has a title. Single best answers look like this. There's a question. There's usually about 5 options, okay? So let's say now you select an option and you get it right. Reading this concise summary is probably enough for you for this topic because you got it right. It suggests that you've got a good handle on it. But let's say now, and this is an example of a multiple best answer. You're picking 3, okay? So now let's say you get one wrong. Okay, if you get it wrong, what you might want to do is read up a little bit more about this subject to do some focus reading, okay? And once you're finished doing all of these questions by subject, you'll have a handle on which are your weakest areas. You could do a bit of focus reading, then spend some time doing timed mocks. So we've got 4 mini mocks, which you can do timed. Then we've got 3 full clinical mocks. Again, you can do those timed or untimed, okay? Alongside this, remember SJT is half the exam, right? Start doing some SJT questions. I'll show you how those look later, okay? So you want to do a mix of that. And then remember that the questions in the exam, some will be about investigations, some will be about diagnosis, some will be about emergency care, some will be about prescribing, and some will be about management that doesn't need prescribing. Some management might be surgical, it might be physio, it might be watchful waiting, it might be referring them back to come back for follow-up after a few months to see if things resolve. So where to do your focus reading from? The Oxford Handbook of Clinical Specialties covers all of those specialties that tend to be grouped. When we looked at the curriculum, things like the ENT, the eyes, things like psychiatry, you could read from here. For the sort of cardiovascular, respiratory, endocrinology, all of those you're going to find here, okay? I'm not suggesting you try to read either of these cover to cover. I'm saying you could use these as reference for focus reading on questions you don't do well at. And then spending one day on the BNF will pay dividends. If you read the first section, which covers principles of safe prescribing, pain management, and prescribing in palliative care, these are always going to feature in the exam. And then read the first page of each chapter will give you an overview of important drug classes for each system. Now, even the latest Oxford handbooks, they are out of date for a lot of things in terms of management, because since they were published, several guidelines have changed. So I often used to get asked this question: where can I read guidelines that are up to date? If there's one specific guideline you want to read, a good place is the NICE website, and specifically the NICE Clinical Knowledge Summaries, NICE CAMHS, okay? But there's hundreds of them. So if you want to read lots in a concise way, what you might find really helpful are clinical case cards. So, I showed you that Jared Herxheimer earlier. That's actually what our team did. Was we went through loads of NICE guidelines and we summarized some key topics and we mapped them to the things that your questions are mapped up, and we update them regularly, usually a couple of times a year, so that they're up to date. So we actually totally sold out of the physical cards. Okay, so they're like this. Okay, we've got high quality card, high quality images which we've licensed. So these are the current guidelines for impetigo. For example, if it's localized and low risk, first line is now hydrogen peroxide, whereas it used to be fusidic acid. It's not first line anymore. This is first line now. Okay. For example, notifiable disease, COVID-19, SARS-CoV-2 only recently added. Okay. Even things like the orbit bleeding risk score, which is replaced has bled. When we look at someone with AF, you look at stroke risk and you look at bleeding risk if you start them on anticoagulation. So the printed ones are out of stock because we're fully sold out. We have ordered another batch. They will arrive by the 1st of December. So you can pre-order those on our website. Masuda will post a link. However, we had a lot of doctors, especially doctors that are want to make a start right now, or international delivery takes longer and costs more. They asked whether we could develop a digital version. So we've actually just launched that last week. So it's exactly the same content. These have been updated as of November 2021. So they're fully up to date. Okay. So essentially, you could either look at it on like a computer, you could look at it on a tablet, you could look at it on a mobile device, anything with internet access, you'll be able to look at it. And, it comes with, if I just make it full screen, I'll show you. So you've got like a list of the 112 topics that are covered, okay? And then you'll see that you can have it like this, 2 to a page. There's the NICE hypertension guideline, a bit more detail. How do you actually assess it? Okay. And so on. Or you can, if you prefer, like some people prefer to have it 1 page. Okay. So you can actually change that and toggle it to be, just 1 page and so on. Okay. So anything with internet, you can access it from. So that's where you can get the digital ones. If you use this code, so that's CCD, all lowercase, you can get a 20% discount on a 1-year subscription. And as I said, most of you are already using our online service. For those that aren't, if you haven't started, please make a start. If not today, make a start tomorrow. You haven't really got much time between now and the exam. So ours is the original question bank for the MSRA. We're the first people to develop one. We update it every year. We've got over 2,100 questions mapped to the curriculum. They're in the right format, both clinical and SJT, full mocks for both. You also get additional learning materials sent to you, short animations and things like that. It will take about 100 hours of learning time if you want to cover all of them in one go, okay, once. So if you go to our website, which is emedica.co.uk, this is all the stuff for MSRA. So the online questions are here, okay, and it's anywhere you can subscribe from a month to 12 months. So you'd need 2 months to cover you to the January exam now. So it's from £49 for a month up to 119 for 12 months, okay. So let's talk about professional dilemma questions now, and then we'll take questions and I'll summarize. So the basics of the SJT or professional dilemma paper. By the way, in the real exam, this will come first. It's 95 minutes and you're going to answer 50 questions. Only 42 are marked. So there'll be 8 pilots that don't count. Again, they won't look different. You take all 50 seriously. You can see I've put timing. Both papers are time pressured, but a lot of doctors find this one more time pressured than the clinical. So there's 2 sections. About half the questions are section 1, which are ranking questions, where you rank things from best to worst. About half the questions are section 2, which are selection or multiple choice questions, where you select 3 options that work together to deal with the scenario. Okay, so let's go into why they're using this. So the reason that they're using this, before this, they used to use essay type questions, which are very subjective, and there wasn't good correlation between people that were good at writing essays and people that were good at the job. So they wanted something validated, objective rather than subjective, and essays can't still be marked by computer effectively. They need something that could be marked by machine. So what the SJT will do is it will give you a work-based or work-related scenario, and there might be difficult situations or professional or ethical dilemmas. And what they're doing is checking, is your decision-making and judgment under pressure of time sound? And do you show positives for 3 key competencies in the National Person Specification that they're looking for? And they are empathy and sensitivity, professional integrity, and coping with pressure. Now, each of these is broken down into lots of subdomains. Specific questions will target specific subdomains. Okay, and then for some questions, having a good working knowledge of core GMC guidance and how to apply it will make some questions easier. So 2 sections, 2 approaches. Section 1 are ranking, section 2 selection or multiple choice. Now, although they're about 50-50 in terms of questions, section 1 questions are each worth more than section 2. So about more than 2/3 of the marks are actually in section 1. Okay, right, so let's go through some sample questions. So in section 1, you get a scenario, could be based in hospital, could be based in GP, and usually you'll be asked to rank 5 options, 1 to 5. Some questions will have 4 options. So if there's 5, 1 is the one that you think is the best or the most effective, 2 is the next best or most effective, all the way to 5 is the worst or least effective. To finish all the questions in time, you've got about 1:53 per scenario. So let's do a question. Here we go. Okay, that's time. So please write your order into the chat. I can't launch a poll for this. So just write your whole order into the chat. Right, okay. So I can see that a lot of different choices. So some people have started with D. So we've got DEABC by some people. Some people have got DAEBC. Some got DBECA. Some have got ADEBC. Some have got EDBAC, EDCBA, so a huge range of options. Okay, so one of the things with the SJT, you've got about minute 52, minute 53, right? You haven't got time to come back to these. You want to be finishing the last question just a few seconds before the buzzer sounds, all right? Because if you come back to an SJT, you end up having to read the whole thing. Unlike a clinical, you can flag for review and you might come back, you'd already narrowed down to the last 2, for example, okay? So as you're reading, read carefully, try to picture the scene. It will really help you, okay? So let's just do that read through. So you're just finishing a busy night shift and you're exhausted. Now the morning doctor's called in sick. Now bear in mind, all of the questions, you need to imagine you're at the level of an F2, okay? So someone at your level is called in sick, the morning doctor. And as you're about to leave the ward, the senior nurse says, look, can I speak to you? And she basically tells you, look, medical staffing are asking, would you stay on until the early afternoon? There's going to be a locum available then. So you can see, you can deduce from that, they've found a locum, but they can't get there till later. But look at this bit, you're barely able to keep your eyes open and you can't concentrate. So picture that scene, there's finishing a night shift, you'll always be tired. Then there's exhausted. Then there's, when you're so tired that you're sort of like this, okay, nodding off. Is it safe for you to be seeing patients when you're in this? Because do you remember we talked about these 3 domains: empathy and sensitivity, professional integrity, coping with pressure. Well, part of coping with pressure is knowing your limits and knowing what's safe and not safe, okay? It's not safe, right? Okay, good. So let's look at the preferred response. So the preferred response is DAEBC. DAEBC, all right? And I'm just going to highlight that, this is a challenging question. So I'm just going to launch a poll. I just want you to select A if you had exactly that order, B if you had any other order, even if you had only like 2 of them the wrong way around. So A if it was exactly DAEBC that you picked, B if you picked any other order. So less than a quarter of you, actually now a few more people have clicked, yeah, only a fifth of you, only 20% of you had DAEBC. 80% of you didn't have exactly the perfect order. Now the good news is, even if you don't have exactly the right order, you can still get a lot of marks in section 1, because the way that it's marked, I'll come back and explain this order in a minute, but let's look at how it's marked. So section 1 questions are marked using keyed responses marking. So if there's 5 options, there's 20 marks maximum. If there's only 4 options, there's 16, okay? So if you had 5 options like this one, if you had all 5 correct, so you had exactly DAEBC, you get 20 marks. But if you had the incorrect answer, you get somewhere between 8 and 18 marks, depending on how close, 8 and 18 marks, depending on how close you were to the perfect response, okay? It's called keyed response because every single combination has a number of marks keyed to it. So for example, some of you might have had A and D the wrong way around, but you had EBC here. So you had AD, EBC. That would be keyed to be worth 18 marks because although it's not perfect, it's actually very sensible overall still. Similarly, if you had DAE and you had B and C the wrong way around, you'd still get a lot of marks. Whereas if you had these 3 in the right place, but you had C at the top and D at the bottom, you've still got 3 right and 2 wrong, but you'd get a much lower mark because overall it's not very sensible. It's not very close to the perfect response. So it's not just about how many were in the right place and how many were in the wrong. It's exactly what is your order. Every single combination has a number of marks keyed to it. Okay, so that's why it's called keyed responses marking. All right. Now it's called situational judgment because we appreciate there will often be a difference of opinions. And that's why, even if your answer is not perfect, but it's still sensible, it's close, you'll still get partial marks. All right. So let's explain. Now, just before I do explain that, quite a few of you had A first when I looked in the chat. Okay. And D second. Now you'd get a lot of marks for that. If you had A, D, E, B, C, you'd get 18 out of 20. That's good. That's 90%. I don't want you to get 90% though. I want you to get them all. I want you to get 20. So just type into the chat, all of you that put A first and D as number 2, rank number 2, what made you put A number 1 and D number 2? Just tell me in the chat. Reasoning. Okay, so a couple of people have said that it's going to take longer to get hold of the clinical supervisor, and that if you let medical staffing know that you're not going to do it, they can start finding someone sooner. And someone else said that they felt that it deals with it as a first step sooner. So let me just try and paraphrase what a few of you have said. A lot of you that put A first and D second, were you thinking, this is quick, I can say no, they can start looking for someone, and then after that I can discuss it with my consultant, that's going to take longer, okay? And to explain the whole situation, you can see that that's going to take a longer time. And is that what some of you were thinking, that you thought, I'd do this first and then I'd do this? This is my first one in terms of time order. Is that what some of you were thinking? Yeah, so quite a few people have said that. So this is the most common reason for losing marks in section 1 questions is that people that are thinking about which order would they do it in a sequence of time. They're thinking, I do this first, then I do this, then I do this. Then if you think about it like that, you are regularly going to lose marks that you could have got if you changed your mindset and approached it the right way. In section 1, each option has to be looked at as a discrete or completely separate option. They're not asking you which would you do first and which would you do next. Now that can be confusing because if you read this, it says rank in order the following actions, right? And if you just read that, it'd be easy to think that. But look at what it says. 1 is most appropriate, 5 is least appropriate. When you're looking at this, you have to imagine the key word is not then, it's or. If you could only do one of these, and that was your whole response to the situation, which would be the most appropriate or most effective or best response? Would it be A or B or C or D or E? If you could only do one, not I'm going to do this first and then I'm going to do this in a sequence of time. If you think about it like this, you're going to regularly lose marks. Okay, so you're comparing one to the other as if it's the only one you're going to do. You're not going to do all of these. You're only going to do one. Which one? So let me explain now why D. If you could only do one, why is D the best one? It all goes back to what the questions are about. The questions map back to those domains: empathy and sensitivity, professional integrity, coping with pressure. And as I said, they've got subdomains. One of the subdomains of coping with pressure is to know your limits. Okay. In both of these, you're not staying on, so you're recognizing your limits. Okay. That links to your limits, but also links to patient safety. Okay. In all of these, you're adding risk. So they rank lower. Within these, though, if you could only do one, why is this one better? Because this one also shows a positive for another domain, which is professional integrity. One of the subdomains of that is challenging inappropriate behavior. And also part of being a good team member is to keep your colleagues, part of your role is to keep your colleagues informed. So if you look at D, it shows positives for more domains. Look what's happening in D. If this is the only one you could do, if you're discussing the situation, that means the whole thing with they'll use this term in the exam to mean basically your consultant, your supervisor, okay? Your consultant. So what you're saying is to your consultant, look, I'm really tired, the whole situation. I'm really tired, I can barely concentrate. I've just finished the night shift. They've asked me to stay on and I really don't think it's safe. You see, it's clear you're not going to do it. But if you just say no, like medical staffing know that they shouldn't ask someone. There are legal limits to how many hours you can work in a row at night. You have to have so many hours compensatory rest after a night shift. Don't think that medical staffing don't know that. But sometimes when they're a bit stuck, they'll try and ask a junior doctor who, being naive and thinking I'm being helpful, will sometimes stay on, be at risk to themselves and patients, do something, make a mistake, then they'll wash their hands off you. When you get to the GMC saying, they asked me and I was helping them out, you need to know your limits and you shouldn't work beyond your limits. The fact that you did, you're unsafe. Can you see that suggests poor judgment? That can be a fitness to practice issue. So can you see here what you're doing is not only are you recognizing your limits, but now the consultant knows that we're down one F2. Can you see it's in their power to say to the registrar, like, look, you'll have to hold until the locum arrives. I'll manage clinic, for example. Okay. But you see, by telling them the whole situation that medical staffing have asked you, you could say no, but you might not feel that you've got the power to say you shouldn't be asking me, but your consultant has that power. You see, you're also challenging the inappropriate behavior by letting someone with more authority know that they're asking your juniors to stay on when they're too tired after a night shift. You see, D is the most complete answer. If you're only going to do one, D shows positives for lots of domains. Okay. Now, if that wasn't an option, and you had to pick out of only these, not to do as the next thing, not in an order of time, as in imagine that there were only 4 options, A, E, B, C. A would be the best one of what's left. Why? Because you're recognizing your limits and you're not doing it. Okay. Now, if we look at B and C, okay, both of these put yourself, colleagues, and other patients at immediate risk in that you're barely able to concentrate and you're staying on for a few hours to cover the on-call. So what makes B not as bad as C is that in B, it doesn't mention your motivation. You're being unsafe, that's all. In C, you're being unsafe, but then you're also trying to take advantage of an emergency. You're saying, I'll do a few hours, but you've got to give me a full day back. And you're asked to rank what a good doctor should do, not necessarily what you would do in real life. If you're really tired and you don't want to do it, you know what? you might want to ask for locum rates or something extra, but you shouldn't in an emergency setting. It's different if they ask you, would you cover a locum, on next month on a bank holiday? It's fine for you to ask for locum rates because that's planned. But in an emergency, you shouldn't try to take advantage. And that's what C is. So now we're left with a lot of you actually put E first. What's the problem with E that makes it lower than DNA? Remember, you're comparing with the one above and the one below. Okay. What's the problem with E? Why can't it be higher? The problem with E is this. First of all, if you come back in the early evening, you don't need to come back in the early evening. The locum's going to be there. So you might sound like you're being helpful. They don't need anyone in the early evening. They've already got cover. Do you see? So sometimes people have missed that. There will be cover. They don't need anyone there. But on top of that, what will happen? If you come back in the early evening prior to your night shift, what's going to happen at the end of your night shift? You will have gone over your maximum hours. You would not have had your mandatory rest. You might be overtired and put those patients that you see towards the end of the shift at risk. Easy to miss if you're not paying attention, right? If you don't think about, this is why picturing the scene and then mapping it back to the domains, that's a really important part of technique. Okay, so section 1. Remember, the key thing is that there is one best answer that will give you full marks. Everything else, you're going to get partial marks, okay? But it's important that each option is discrete. Think about the word or, not the word then. So you've got to compare it to the one above and the one below. If that was the only one you're going to do, is it a better response? Does it deal with the situation better than the other one? Okay. Section 2, you get a scenario just like section 1, but it takes longer to read because you get 8 options, not 4 or 5. Here, you're asked to select 3 options that taken together make the most appropriate combined response. So let's do a section 2 question. Here we go. Okay, poll is launched. Please select your answer. And remember, you're going to pick 3. Okay, I'll stop it there. So popular answers are B, D, E, G, and H. So B, D, E, G, and H. Very few people picked A, C, or F. Okay, so again, let's do a read through. So you're treating this older patient, 68 years old. He's got diabetes. He's on the care of the elderly ward following a fall at home. Can you see? We can see that it must have been significant enough to have him admitted. And you notice an unexplained spike in his blood sugar levels each evening. You can see each evening, i.e. it's regular, it's not a one-off, before dinner is served. Now, he's talked about his sweet tooth. Lots of diabetic patients have sweet tooth. That's how they, might have contributed towards their problems in terms of poor control and so on. And you've seen his wife, who visits him every afternoon, that she's bringing him sweets as a treat. Okay, so we're picking 3 here. So the 3 most appropriate actions are B, G, and H. Okay, B, G, and H. Now, lots of you picked G, quite a few of you picked H, less than half of you picked B. And that's because a lot of you that didn't pick B, you either picked D or E. Okay, so let's go through how these are marked, and then we'll go through the scenario. So selection SJTs, or multiple choice SJTs, i.e. section 2, there's only 12 marks for each question. You get 4 marks for each bit that you get right. So you got all 3 right, you get 12. You get any 2 right, you get 8. You get any 1 right, you get 4. There's no negative marking. You don't lose marks, you just don't get them if you get it wrong. And the key thing here is that these are and. The key word is the most appropriate combined response. So they've got to make sense together. Sometimes there'll be 3 options that are all good independently, but they don't work together. So they're not all going to be in the right answer. So let's go back here. Now, because this one is about the 3 best, and actually, let me just show you first of all how you'd actually do it in the exam. So if I show you our SJT questions, because they're laid out exactly how it is in the exam. So for ranking questions, okay, so sometimes it'll be 5, sometimes it'll be 4. Can you see this one's got 4? Okay, so you drag them, and once you've dragged them, you'll just move on in the exam. You'll click next. But here, like when you check the answer, these are marked keyed response, just like the real exam. Okay, for every combination, the number of marks depends on how close you are to the perfect response. None of the commercially available software could do this that we could find. We hired a programmer specifically to code it to mark in the same way as a real exam. So you see, that takes a bit longer. But if you look at the selection questions, just like in the exam, all you're going to have to do is there'll be a scenario, there'll be 8 options. You just tick the ones you want. So let's say you want B, C, and D. You just tick them. You're not ranking any of them 1, 2, or 3. You're just ticking them. And again, you'll get 4 for each bit. So like here, I've only got 1 right. I've got 4 for that. Okay. And then, there's an explanation. So that's how it'll be. So to select these in the exam is very quick. You just tick B, G, and H. Whereas with the other ones, you move things across. Okay. So with these, there's some options that clearly show a negative for one of the domains or clearly go against GMC guidance. You could eliminate those because they're not going to be in the right answer, are they? And then with what's left, you want to pick the 3 that work together when you add in the word and in between them. So they work together when you add in the word and to make one story that deals with the situation. So let's eliminate the ones that there's something wrong with it. So why can I eliminate A? What's wrong with A? Why would you not pick A? Yeah, because of the word confront. Ultimately, this is a patient, they're unwell enough to be admitted to hospital. Do you see? So think about the domain of empathy and sensitivity, that, you should talk to people in a way that's sensitive, that shows empathy. That, look, he can't control necessarily his wife's behavior. To confront a patient about someone else's behavior, there's no situation where that's going to be appropriate, is it? Do you see? So A's out. Okay, C. If at the moment it's high every evening and we don't know why yet, if you measure it less frequently, it might get even worse, and then it would take longer to pick up. So it wouldn't make sense in terms of, safety. And I'm going to leave D and E. I'll come back to them because lots of you picked either one of those. F, this is not understanding your role, first of all. It's not your role as a junior doctor to decide who can visit when. That's the role of the senior nurse on the ward or the ward manager, okay? So it's not understanding your role, going beyond your limits, but also think about the patient's overall well-being. So that's part of empathy and sensitivity, thinking about it from their perspective. They're in hospital. They might really like to have their wife come and visit them daily. Do you see? It's not just their physical health you've got to think about. You also got to think about their psychological well-being and their emotional well-being. So that's why F's out. So now D and E, a lot of doctors picked. What's the problem with D? It's the same problem with E. What's the problem with these two? Why they're not part of the right answer? Yeah, both D and E constitute an inappropriate breach in confidentiality. Do you see? In none of these options have you taken permission from Mr. Jackson to discuss his results. Look, results with his wife, discuss his care and recent results with both of them. You haven't taken his permission in any of them. And so that would be a breach of confidentiality. And this is where knowing the GMC guidance, i.e. knowing that someone who's the spouse or the next of kin does not automatically have a right to confidential information from a patient, that there's certain situations when it would be appropriate to breach confidentiality, but this isn't one of them. An example would be when you're sharing that information to prevent a risk of death or serious harm to the patient or a third party. That's not happening here. So D and E are a negative of professional integrity. Part of that is respecting confidentiality. Okay, now let's look at the right answer and how you know you've got it right before it's marked. That is to add in the word and see if it makes sense as a story. It's not necessarily in alphabetical order. So does this make sense? This is the scenario. Does this make sense? Picture it. Mr. Jackson, I've noticed that your sugars have been a bit high before dinner over the last several days. Can you see? Discuss, not confront, not accuse, and explore his diet. It'd be helpful if you could just talk me through what you've been eating. Let's just go through yesterday as an example. What do you have for breakfast? What was your lunch? How about dinner? Did you have anything else at all? Any snacks at any point in the day? And so you're not accusing, you're just exploring. And suggest some sugar-free treats that he might enjoy. Well, look, as you may have mentioned before that, you like sweet things, but your sugars aren't well controlled. Look, these are some sugar-free treats. So they don't actually have sugar in them, but they might give you that taste without affecting your health. And continue to monitor his blood sugar levels at least daily. Does that make sense as a story when you add in and? It does. That's one of the ways you know you're probably on the way to being right. And then does it better than any other combination of three deal with this situation? That's when you know you're fully right. Okay, so that's B, G, and H. Okay, so how to prepare? You need to understand not just those three domains, but each domain is broken down into lots of subdomains. Understanding that and looking for them when you're reading a question so that you can see this one shows more positives for more domains. It really, really helps. Having a good working knowledge of good medical practice and GMC ethical guidance. Understanding the difference in approach between section 1 questions and section 2. And then practicing ideally realistic questions to time, okay? And then learning the core GMC and ethical guidance. So knowing about the biomedical ethical principles of autonomy, beneficence, non-maleficence, justice, and how they apply, confidentiality and when you can and can't breach it, capacity, advanced refusals, DNA CPR decisions, Gillick and Fraser, consent, Bowler, Montgomery, the GMC guidance from 2020, personal beliefs and medical practice for doctors and for patients, financial issues, raising concerns, safeguarding, all of these different ethical guidance you need to have a good working knowledge of, okay? Now, if you want to cover all of this really efficiently and really prepare, especially someone asked earlier, what if they've not, because they've been busy and not had time to even finish the application yet? What if you've left it a bit late and you want to, is there still time? Absolutely. With lots of doctors that, it's been busy. Everyone's been busy with clinical pressures because of the pandemic. So we have designed a course really specifically to help people who either need to do really well, not just pass because they're applying to a competitive specialty, or they're applying to a limited number of areas so that they really need a good score so they get their first choice, okay? Because, their kids are in school or their partner's applying somewhere as well, or they've left it late and they just want to maximize their chance. So we have a 2-day MSRA crammer course. It's on the 4th and 5th of December. The whole first day will focus on clinical. We'll cover over 100 different clinical topics. We'll do a time teaching mock, full one. We'll look at exam technique, keywords, and how to apply them. The whole day 2, over 7 hours of just purely on the SJT. So we will cover all of these key guidance and make it easy to understand and how to apply it. We'll look at the specific techniques and keywords to watch out, all of the subdomains, what are they and how to apply them. And we'll go through lots of high challenge, high yield questions and a timed mini mock and go in great detail. Like we've just discussed 2 scenarios. We'll be discussing loads of them, okay? We've had excellent feedback over 14 years. We've helped people that have been applying for every one of the specialties that use it, and lots of people to get into their first choice in a competitive specialty. All the questions are unique to this course. They're different to the ones on the online. And when you book the 2-day course, you get access to the recording for a month afterwards if you'd like it, and you get access to all of our 2,100 online questions and mocks as part of it, okay? So, we had, for example, this is from last year, Dr. Ormerod scored 2nd in the whole country in psychiatry and CAMHS, 5th in the whole country for GP, got a job at for CAMHS. They got offers for both, but they took the CAMHS offer in the Maudsley. Okay, one of the most competitive rotations. So this is all of the first day. This is all of the second day, and we've helped people get phenomenal scores. Okay, 629, one of the top scores I ever done. Let me look at common reasons for failure, how to prepare. Then I'll take questions. So number one reason for people to either fail the exam or fail to get a job, because lots of people that pass the exam won't get a job because of competition. I'll give you an example. Last year, 7,660 people applied for GP. There were 4,200 jobs, okay? Over 6,000 passed the exam, but there's only 4,200 jobs. So that means there's going to be, more than 1,800 odd people that passed that didn't get a job. Some failed. So, not allowing enough time. So one of the reasons for that is a lot of doctors wait till after they've submitted the application before they start their prep. If you haven't finished the application, it doesn't matter. Start your prep. Some doctors, they wait even longer. They wait until they get that invitation, but the invitation is expected around the 21st of December. If you wait till then, you're going to have 2 weeks. And you're competing against, it's not a pass-fail exam, it's a competitive ranking. You're competing against people that have been preparing for months. So if you haven't started, please, you've done some today, but start tomorrow, serious study, okay? Underestimating the exam. So you get a lot of doctors that think, you know what, this is really straightforward. The individual level of questions isn't hard, but there's breadth, so it takes time. But on top of that, it's not pass-fail. It's competitive ranking. You've got to do better than other people that want the same specialty as you. Do you see? Okay. Another thing that we see is that people that just focus on one paper, I've seen many doctors that got a really high score in the clinical, but failed the SJT, or got a really high score in the SJT, but just hadn't allowed enough time, because the clinical, even if it's not hard, you need time because there's so many subjects to cover, right? Okay. And so, they just didn't do well. And so overall, their score wasn't good enough to get an interview or wasn't good enough to get a job. And finally, poor exam technique. I've seen some doctors that work really hard on and put the hours in. They do lots of reading, but perhaps haven't practiced enough realistic questions, don't manage their time well, don't understand how to approach keywords or the difference between how to approach one type of SJT and the other, mapping to the domains. And so, they fail on technique. So these are the common reasons. So then how can you do really well? The opposite of all of these, okay? How to prepare effectively, allow enough time. If you haven't started, look, there's a Chinese saying, the best time to plant a tree was 30 years ago. We've missed that. The second best time is today. Okay, so well done on joining today, and you've already done some revision today. Keep it going. Start tomorrow. Okay, so active learning we talked about earlier. Trying to actually do questions. That should be the bulk of your preparation now. Doing questions. If you get it right, read the explanation. Get it wrong, do some reading. Okay, read the case cards if you want to cover lots of guidelines in a quick time. Cover the curriculum systematically. So our questions are mapped to the curriculum. Get a good working knowledge of the GMC ethical guidance. Practice realistic questions. Work on learning the different keywords. Do timed mocks. Find a study partner. If you join either our MSRA support group on Facebook or the GP training support group, you'll find, other doctors that are preparing. It can help to discuss, especially SJT scenarios, but also difficult clinical questions. Okay. So just a reminder, if you just want our questions, you can go here. There's over 2,000 of them. Okay. If you just want the case cards, I showed you where they are earlier. If you book the MSRA Crammer course, you will get the 2 days of live teaching, so 14 hours of CPD, access to the online questions for 6 months. So if you bought those separately, it costs $569. If you go to this page on our website, you don't need any code, the discount's already applied. You'll be able to book it for $449. Okay. Anyone that's already using our online questions, so doesn't need the online questions, we will email you a discount code tomorrow, or email us and we'll send you a code, and you'll be able to get it because you already paid for the questions. If you like, you'll be able to get a discount. Okay. So the 2-day course is here. Okay. So if you just want to book one day, some people just want to book the SJT, for example, you can book that. That doesn't include the online questions. You need to book that separately. And then you can access the recording afterwards as well. Okay. And I'll just take questions in a minute, but just to highlight, look, I showed you this is Dr. Omrod earlier. This is someone that got a direct offer for GP. They particularly found it helpful to understand the SJT questions. Radiology, the Crammer course was invaluable. They really found it helpful. This doctor's actually now in ST2. Direct offer for psychiatry, really high score. This doctor is an international graduate. Not only did they get an offer for ophthalmology, but in London Deanery, so one of the most competitive jobs. Okay, again, they found it really helpful to do the course. And then reminder of this is where you'll find it. It's code is CCD. Let me just summarize. Okay, please join the support group either for MSRA or GP training or both. Subscribe to our YouTube channel if you'd like to access the recording in a couple of days. Remember, this is a 2-part assessment. They're equally weighted, so you need to give both time. Whether you get shortlisted to interview or not, and then even if you do, the score carries over, your rank will be impacted by MSRA. For GP and Psych, there's no interview, there's no portfolio, there's no OSCE. 100% of your chance is based on this. For a lot of other specialties, you need to do really well in this to get that interview slot. So it's competitive ranking, not pass-fail. Don't aim for the minimum, aim for the maximum. Every mark could be the one that makes a difference, okay? just passing often isn't enough to get an interview or a job. So focus your revision, practice under time conditions, make the most of every day between now and the exam, prepare and you will succeed, okay? So, leave you with 2 messages. First, from Michael Corder: to succeed, we must first believe that we can. Sometimes doctors say to me, look, I really want London, but I know it's really competitive, so I'm not going to bother. If you've got that mindset, you're right. You're already not good enough for London because you've already decided that. That was you that decided that. Someone's going to get a job there. Why can't it be you? But if you say, I can do this, but I know it's hard, so I'm going to work really hard, and you put the hours in, you'll get it. Similarly, if you really want to be a radiologist, don't settle for a specialty. You're going to spend the next 40 years doing this. You've got to love it, okay? So if you know that it's hard because it's really competitive, you're going to put the work in. You're going to do everything that you can to make sure you get that interview while you're also working on your portfolio and interview technique to make sure that you do well when you get there, okay? And if you don't get it, you're going to say, you know what, that's a learning experience. I'm going to have even bought a portfolio. I've got a year to prepare for next year. I'm going to smash it. And then you get in, and then you'll be a radiologist in a few years' time and enjoy the rest of your career. Don't, because you didn't get in, do something that you don't really want and you're not really into and not passionate about for 30 years. Don't think about a 1 year or 2 year timescale. Think about a 30-year timescale. That's really important. And then from Malcolm Shabazz, Malcolm X, the future belongs to those who prepare for it today. Thank you for joining, giving up your evening. I know how precious that is for all of us. I hope you found it helpful. I hope you got a much clearer idea of the exam, how to prepare, the difference between section 1 and section 2, what kinds of subjects are covered, how it's competitively ranked. Now it's up to you. Do the work. Every day, do some questions, read some guidelines, revise a few topics, go over a few case cards, put the work in, then the future will belong to you. So huge thank you for joining. Huge thank you to Masuda for answering all those questions. For anyone that hasn't got questions and is leaving, please keep pushing. I might see some of you on the 4th and 5th of December at the live sessions. For all of you, all the best in getting your first choice job in your first choice area. Please do let me know how you get on. Prepare and you will succeed.